Well, good afternoon, everyone, and thank you very much for joining the annual general meeting of the NHS Sussex Integrated Care Board, or NHS Sussex as we prefer to call ourselves. It's good to see so many people online today. There's many faces and names that I recognise, so thank you for making the time to join us. So just by way of introduction, my name's Stephen Lightfoot. I'm the one speaking over here. I'm the chair of the NHS Sussex Board, and my role today is to lead us through the next 90 minutes. And I'd just like to take a few minutes now, if that's okay, just to set the scene in terms of what to expect. I also just need to make you all aware that the virtual meeting is being recorded. And I think now will be a good moment just to put the slides on screen, if that's okay. So I think what we'd like to do over the next half an hour is really to take the opportunity to review the last year from April 2024 through to March 2025. And we need to formally present our annual report and accounts for that particular period. And then, of course, we're going to look forward to what is ahead for the organisation and the ambitions we have for improving the health and care and the health of the communities and residents of Sussex. We then actually would like to spend most of our time today, probably at least 50 minutes or so, answering as many of your questions as we have time to go through in the time we have today, because I think that's a really vital part of the engagement exercise that we're on today. Now, I'm pleased that I'm not going to be doing this on my own. In a moment, I'll be handing over to our Chief Executive, Adam Doyle, and we've also got our Interim Chief Finance Officer, Carla Moody, and they'll be joining us along with all of the other NHS Sussex board members who are online today. So I think on that basis, can we just move on to the next slide? That would be wonderful. So in terms of the board members, we've got all the names on the screen there, but in principle, in addition to myself as chair and Adam as the chief executive officer, we have 6 executive members, 6 independent non-executive members and 6 partner members. And as I said, they're available to be able to answer questions for you this afternoon. I think also what's particularly important is that I would just like to record my formal and sincere thanks to board colleagues for what they've done to support not just me, but also our organisation and the people of Sussex over the last year. I must admit, I'm really proud of the board that we've built, with not only the depth, but also the breadth of experience and the diversity of experience that they bring. So thank you to each and every one of our board members. Detailed biographies of each of our directors and also their register of interests are on our website. And you'll be able to see them also in our annual report if you wish. But we need this level of experience to manage what is effectively the 10th biggest integrated care system in the country. I'd also like to just take this very brief opportunity to thank Hannah Hamilton, Paul King and Joe Chadwick-Bell, who were all members of our board during the reporting period. And also just to recognise the departures this week of Louise Ansari, who's been appointed as a non-executive director on the NHS England board as of Monday, and also Vince Clark, who left his role at West Sussex County Council just yesterday. So I think in terms of that's the board, and so with the colleagues that will be here to answer questions later. If you just move on to the next slide, please, Michael. Just in terms of what we do and what we're responsible for, just to be really clear, NHS Sussex is accountable for improving the health outcomes and reducing the health inequalities of the 1.7 million people who live in West Sussex, East Sussex and Brighton and Hove. And we're also responsible for maximising the value for money from the £4.5 billion of public funding we receive. And of course, supporting the social and economic growth of our local communities, because the NHS is a major employer in Sussex and we employ something like 43,000 staff across all the different NHS organisations in the county. But Adam will explain more about that, as will Carla, on how we spend the money. In terms of the next slide, please, just to move on to the agenda, we do need to formally note the minutes of last year's annual general meeting, which was held virtually on the 25th of September 2024. The minutes were approved at the NHS Sussex board meeting held in public on the 27th of November last year and were then published on our website. We intend to follow a similar process this year, and so the minutes from today will be presented at our board meeting held in public on the 24th of September this year, and again will be published on our website. Also, everything we present today will be available in our 189-page annual report, which is also available from our website, but also paper copies are available if you would prefer, and they can be achieved and obtained on request. So then just briefly, a few sort of housekeeping rules, if that's okay, on the next slide, just in terms of for the format of today. Just to make you aware, the meeting is being recorded. It will be available on our website after the event. We do ask that you keep your microphone muted so everyone can hear the presenters. And also there's a Q&A box on the webinar, so you can ask any questions during the presentations, and some of my colleagues may be able to answer some of those during the meeting as we go along. I suppose it is important just to make sure that everyone is fully aware that other attendees will be able to see your name and any comments or questions that you post. So we do ask, with all due respect, to please be mindful and respectful when using the chat function. What we'll do is we do have a pre-submitted question which we'll answer, but we'll also take as many questions as I can during the Q&A session. And if we don't have time to answer all the questions that are raised today, we intend to publish the questions and answers, all of them in fact, on our NHS Sussex website after the meeting. So that really is just in terms of why we're here, what we do, and how we're going to run today's meeting. So in the interest of time, I'm very keen just to move straight on if that's okay. And so I'd now like to ask our Chief Executive Officer, Mr. Adam Doyle, to present our year in review and our annual report for 24 to 25. Adam, over to you.
Thank you, Stephen, and thank you everybody for joining us today. So it's my job today to reflect back on 24-25, what went well and where there were challenges. I aim to really focus on three main areas. The improvements we made and in terms of outcomes for 1.7 million people we have responsibility for, the progress we've made on our longer term plans to address the sustainability of the NHS in Sussex, and of course the focus on our organisation and our workforce as we have underwent and continue to go through significant organisational change. But let's start with our community. And we've made real progress in a number of key areas. And it's really important that, we're not complacent, but every year we compare how we performed this year versus last year. And I think in many respects, 24-25 was a really good year for the NHS in Sussex. It doesn't mean that sometimes people aren't waiting too long and care could not be improved, but in many areas, we have seen a great focus and improvement. So elective care, for example, significant progress was made in reducing the number of patients waiting over 65 weeks within our system. And we ended at the end of March with 529 people waiting more than 65 weeks. That's a major reduction from the 4,000 people who are waiting at the same point the year before. And it's really key that we're now edging close to 60% of our patients are treated within 18 weeks. For cancer, we achieved a compliant position against what we call our faster diagnosis standard, which is basically the numbers of people who are waiting less than 28 days for cancer diagnosis. That's across all of our providers, and we were slightly above and ahead of our plan, which is really positive. We've also seen improved performance against the 62-day cancer standard, which is when people get treated with that diagnosis. So that also improved in comparison to the year before. For diagnostics, we've also seen the numbers of people being seen within 6 weeks and rise to 87%, which is really important. What does that mean, though? So last year, we performed just over 900,000 diagnostic tests, and that's 50,000 more than we had planned to do. So really positive, getting people access to diagnostic testing really quickly, and the vast majority within 6 weeks. We've also established unscheduled care navigation hubs where basically we're trying to say what is the right urgent care service for our patients if we can avoid them going into ED, and that really worked well. And in our emergency departments, we are still seeing, and I'll cover it in a moment, too many people with mental health conditions waiting above 12 hours, but the numbers of attenders have reduced significantly since October and in line with the plan that we submitted. We also have a responsibility to look at the role of primary care and particularly general practice across our system. And in March 2025 alone, just under 1 million GP appointments were offered. So, it really shows the breadth of appointments that we're offering across the service. 60% of those were face-to-face and 56% were with a healthcare professional other than a GP. And that's a 2% increase from March the previous year and a 20% increase from the year before. We've had a lot of people, come to us since we take on the responsibility for dentistry to ask us to make sure we can improve access. And we're really pleased that over a third of adults who need to be seen by a dentist have now been seen. There is still a way to go in that, but that has improved dramatically since we inherited the dental responsibilities. And our pharmacy colleagues have really increased, from about 8,000 contacts a month to 14,000 by the year end. So, people are starting to use alternative care pathways across Sussex, and that's really, really positive and a great development that we're seeing. We've also worked really hard to address health inequalities. And one of the key areas that I've spoken over a number of AGMs over the past number of years is making sure that those people who don't always access healthcare services well, or we don't provide the right access routes for them, we give focus to. And I'm really pleased that we've met the annual health checks for people with learning disabilities, and for the first time, we've met the same for those with severe and enduring mental health illness. It's really important. Both those cohorts of our community do have worse health outcomes. So it's really important that they get a comprehensive health check every year to make sure that we are therefore driving that forward. So whilst, I'm very proud of what the teams have delivered, this isn't to pretend that everything was perfect. And we still know there were times when people were not offered the level of care that we wanted for our population. And the key areas to focus for us now are to eliminate the numbers of people waiting in our emergency departments with a mental health condition. And also, we know we have people waiting a very long time for children and young people's assessments, particularly in the context of neurodiversity. And then the last area that we've got an improvement plan to focus on is making sure we can get people discharged out of hospital in a really timely way. So that's kind of how the year went operationally for the system. But it isn't all about the here and now. And last year, we also kept our focus on the future. And right at the heart of that is our development of 13 integrated community teams. And in 24-25, we agreed the geographical footprints for each integrated community team and developed their community health profiles. And I want to say a big public thanks to our public health colleagues and the local authorities for helping us with that work. We developed and agreed what the core offer and outcomes would be across those 13. We evaluated the Frontrunner project in Crawley, East Brighton and Hastings, and we tested a winter scheme to support people who are at risk of their health conditioning deteriorating over that period. And we've now got leadership groups which comprise of a GP lead, community pharmacy lead, community health teams, our voluntary and community sector, and others in each of those areas. We also started a service review to consider how do we truly shift from a reactive, institution-centric care model to an integrated model going forward. And in our board in September, we'll be considering the work that our clinical teams have done on urgent and emergency care and rehab and reablement. It's also key, we do want to make sure that we can get access to people in a way that is meaningful for them. So whilst not everybody wants to have a digital access to their health service, a focus on digital remains, and we've now just got just under 1 million registered users of the NHS app in Sussex. That means 58% of the Sussex population aged 13 plus are now registered. And that's an increase of 100,000 since we started taking that forward in August 2023. So we're trying to also make sure the app becomes the digital front door for many of our services going forward. So I've covered how we're performing. I've covered then how we're sort of trying to go forward, but also I can't really sort of ignore the fact that we lead an organisation that has been through quite a lot of change. And during the year, we completed our restructure to reduce our running costs by 30%. And whilst we'd started that in the previous financial year, the impact of those consultations were felt in the year with people being matched into roles, interviewing for jobs, and some moving on to pastures new. It wasn't easy, and I know the impact it had on colleagues, especially as we were also trying to make sure they were still focusing on delivering all the improvements that we've outlined before. We agreed 4 high-impact actions to support our colleagues, to refresh our behaviour framework, to develop a leadership compact, to develop a new digital training system, and focus on maximising the potential of everybody working across the organisation. Over the summer, we had a focus on speaking, listening, acting up, with training across all directorates and support for primary care. And we also launched our Commissioning for Improving Lives Together programme, which is our commissioning development programme for the organisation. And we held our staff conference in October, and you'll see some of the pictures on the screen. All of this continued through the winter months, and we were then really focusing at that point on the year end, how we're going to deliver all these things. But we can't really talk about our workforce without talking about the very significant announcement we had on the 13th of March. With national reforms announced to all ICBs across the country. And I'll talk a bit more about that in a little while, but it has to be said, it has been a very difficult process for many people. But I want to thank our staff. I want to thank all of our partners, and also want to thank, the wider system for continuing to work really well to improve care for our community. Now, we can't talk about the services that our commissioner provided without also talking about the resources. And in reality, one of our very important roles is to make sure we are distributing the NHS funding that we're given in the most appropriate way. And for those who work closely with us, you will know it's been increasingly challenging with cost pressures due to inflation, industrial action, and rise in demand. There was a significant amount of work to achieve our financial plan last year, and I'll hand over to Carla to share more about our approach and our overview of that year from her perspective. So Carla, over to you.
Thank you very much, Adam. And hello, everyone. I'm Carla Moody, and I am the Interim Chief Finance Officer for NHS Sussex. I'm just going to spend a few minutes looking back to 24-25, and over the next couple of slides, I'll take you through a summary of the annual accounts and the financial position for 24-25. So we'll start with a summary of how we spent the money. So in the period from the 1st of April 2024 until the 31st of March 2025, NHS Sussex continued to work with our system partners with the aim to ensure that the system remained within financial balance, working within our financial envelope, and in line with the NHS financial regime, that we all work together to deliver a break-even position. You can see from this slide how we spent the 4.4 billion allocation that we were given for the last financial year. And looking at the summary of where we spent our money, you can see that the majority of the funding went to acute services, so that's for hospital services. And then the other areas where we spend a significant proportion of the money also include primary care, so that includes GP services and dental, mental health services, so that's all the services starting from those focused on identifying those who are struggling with mental health issues, right the way through to those who escalate into crisis and need urgent help. We've also got community services, so those are the services that allow people to be treated closer to their homes, and also prescribing, so that's all of the medicine and all the treatments prescribed to people living in Sussex. So that's just a brief overview, really, of where we spend the allocations that we receive for the population of Sussex. Moving on, I'm just going to give a summary of the audited accounts. So the accounts for NHS Sussex have been formally audited, approved and signed off, and they're available on our website. The slides show that the ICB achieved an unmodified opinion on the financial statements, which give a true and fair view of the financial position and were properly prepared. The ICB also received an unmodified regularity opinion, and that basically means that we've spent all of the the money and recorded it properly in line with all of the regulations set out for us and intended by Parliament. So that's really positive as well. And I think just moving forward, it's really important just to share that like other systems across the country, NHS Sussex really faces some significant financial challenges as we move forward into 25-26 and for the years ahead. So working with our system partners in 25-26, we have put together a break-even plan, and we are closely monitoring delivery of that. But it's been really difficult. It really hasn't been easy. And Adam will talk to you a bit more about that and what we're doing to address that financial challenge. As I said, we are working really effectively with our system partners to look at all areas where we can ensure that we're working efficiently and effectively together and making the best use of our collective resources. So that's it, really, just a very brief summary. Thank you very much. I'll hand back to Adam now, who will share with you some of our forward plans and ambitions for NHS services in Sussex for our residents and our communities.
Thanks, Carla, and thank you for that really helpful and simple summary of our finances. I really appreciate it. So whilst we reflect on the past 12 months, we can't ignore the fact that there are significant changes ahead. I've kind of covered off, the announcement, back in March about the reduction of running costs to ICBs of 50%. So at the beginning of April, NHS England published guidance that ICBs would have to operate within a financial allocation of around £19 per head of population. And then at the beginning of May, we then received the model ICB blueprint that was very clear that ICBs have to really transform now into their central and critical role as strategic commissioners. And there's a view that will be central to delivering our 10-year plan. But clearly, reducing the headcount of the organisation by 50% was a big ask. And our board asked our executive team to consider two options about how we could achieve this ourselves and how we could do this with a partner, namely Surrey Heartlands. And as a result, our board agreed in May a plan for collaborative working with Surrey Heartlands on the basis that a larger financial operating model will retain the capacity, the capability and resilience to deliver the ICB functions as required by NHS England. And it's really important. There are long-established health partnerships across the two geographical areas already. The plan was submitted in June and we gained support from NHS England and ministers at the same time. We are now waiting for financial agreements to be able to take forward some of the organisational change processes that we've agreed. And it's expected that our cluster arrangements will be in place from October. Before I carry on, I think somebody may not be on mute and I think we can hear you, and I don't think you probably want us to. Thank you. There will be chair and CEO processes to appoint cluster roles, and we're able to announce that Ian Smith has been announced as the chair of NHS Sussex and Surrey Heartlands going forward to become NHS Surrey and Sussex from the 1st of April 2026. And then we'll go through the process to appoint our new chief executive and also our new executive team. But we're very clear, we're all steam ahead to merge the organisations at that point. Now, during these AGMs, we tend to focus on the support of our Sussex population, and it is really key. We have some vibrant partnerships. We've got a great VCSE community, a great hospice alliance. People really want to work together to deliver our strategy. But as Chief Executive of NHS Sussex, it's important also to acknowledge the uncertainty of the change process that it causes for our staff, and their continued commitment to the work they're doing is evident. From Stephen and myself, I want to thank every member of staff for their hard work this year. It's been a really busy one, often very tough, and the commitment of many people has never wavered. The dedication, skill and compassion of our team is really key, and I want to thank personally my leadership team for their support to me and the wider organisation. The transition will be a significant change. We can't escape that. But I'm really proud of the work we've done over the past 3 years. And I think we've got really good foundations as we move to this next chapter. In terms of our role as an integrated care board, I've been clear, however, we've got to deliver the changes coming, but we've also got to deliver our operational financial plan for this year. It's been a pretty tricky planning round for the NHS locally. but the plans that have been agreed seem to be now having great impact, and we're pretty confident about our overall plan going forward. However, we've also been really firm that making sure that all the changes we're making don't have a detriment on quality. And we've started this year, as I covered earlier, still seeing a step change again in improvement in performance and positive early progress in primary care access, elective recovery and prevention. And our primary care colleagues are stepping up again. So we are delivering more levels of appointments per 100,000 populations. We're getting more people through pharmacy. So we're planning to forecast meet all of our milestones to ramp up primary care access again. Stephen covered it, but we're delivering strong performance, particularly in A&E performance at this current point, and our waiting lists are coming down quite significantly across the wider NHS. And we therefore, the last thing we're focusing on is make sure that any areas that were a performance outlier, we're scrutinised via our board for our commissioning outcomes and improvement plan. So in terms of the future look, right, so the modelling for our system says that that the NHS in Sussex receives 186 million of funding that may be over what we should get under the national allocation. So what we've tried to do is work to build a sustainability plan where we can try to manage with a different redesign of services, how we can therefore take the money out of the system, but still deliver high and cost-effective care. We've started this with our major services review, and I covered earlier, we'll be discussing that and the models of care where we're changing for urgent care and rehab and reablement at our board in a couple of weeks. We've also developed draft commissioning intentions for 26-27. They'll also come to our board in September, but they reinforce our role as a strategic commissioner. They reinforce that we are committed to doing the shift of hospital care, and they reinforce that our 13 teams are really important to deliver care. We are still interested in any feedback of that. So many people who are on the call are giving feedback, but we would love some more. So if people want to give us anything else they think we might have missed or areas to approach it, we'll therefore take that forward. And if you go on our website, you'll find the ways to really give us your meaningful feedback. You may also be thinking about how this will be taken forward by a new merged organisation, but we're very clear, both us and Surrey Heartland, our population and a local solution that delivers integrated community care is key to both organisations, and we'd expect that to drive forward under the new cluster arrangements. So we'll work really closely with all colleagues and partners on our call who have a direct relationship with. We'll keep all of our plans under review, but while we've got a significant change progress to go through to become a new organisation on the 1st of April, we are focused on delivering our operational plan, working on our system sustainability, and therefore being really clear about what the new models of care for the future look like. And as I speak to people, I've had a really fortunate day today. I've been part of a very big workshop reflecting on our commissioning plans for next year. And I've been really struck by the level of commitment and confidence by our partners. And when you do a job like mine, it's often you have to look at, are our patients getting a better service, and where they are, that's great, and where they're not, how be intervening. But when we're looking for the system to change how it's working, you do get a strong level of confidence when you see how people are working together today. So, broadly, we have a plan. Broadly, we are now in line with delivering it. Our job now is to make sure that we work together with colleagues to therefore respond to the needs of the now and the needs of the future. But with that, I'll now hand back to Stephen. Stephen, over to you.
Thank you, Adam, and apologies for the technical issues that we've been having today. We're not on our own site actually, so unfortunately that sort of got in the way of the film. But if we can have the opportunity to show it, we absolutely will. But I would like to also just thank Adam and Carla for their presentations, and that was actually really helpful and giving us a good overview and summary. So I think we can take the slides down now, if that's okay, and we can move on to questions for the board. I know we've got one question in the Q&A function, which we'll come to in a moment, but if anybody else wants to raise a question either through the Q&A function or alternatively by appearing live and actually putting your hand up, then again we'll be able to do that. But just before we do that, I would just like to, and while you're collecting your thoughts, just like to emphasise the point Adam made about, our commissioning intentions. We're currently conducting a public survey on our draft commissioning intentions for next year. You can find them on our website. We've already had nearly 1,300 responses over the last 4 weeks. The survey closes on Sunday, so if you haven't taken part yet, it will only take a few minutes, but it will absolutely help us to understand really what is important for the residents of Sussex when it comes to local health services. We don't want to take the feedback we've had previously for granted, and we obviously want to continue to refresh that. So if you have the opportunity, then please take it. Now, I did say in terms of answering questions, we're happy to take questions on any topic that's related to NHS Sussex. I'm pleased that we did have one pre-submitted question, and so I'll just read that out if that's okay. And the question asks, is NHS Sussex aware of the contrasting performances of GP surgeries across Sussex, whereby 15.7% of these Sussex surgeries require improvement compared to 1.4% in West Sussex? In practice, very few people have a genuine choice of GP surgery, especially in rural areas. So these statistics indicate a significant inequality of access to good quality primary healthcare. How does the NHS Sussex ICB explain this contrasting performance, and what programme does the ICB have in place to support the GP surgeries that require improvement to actually make these improvements and to monitor their progress? So I think that's the question that we've been asked. And so what I'd like to do is maybe ask Amy Gallier, our Chief Integration and Primary Care Officer, maybe to give us a quick response to that. Amy?
Thank you, Stephen, and thank you to the person who submitted this question. It's nice to be with you all again this year. In terms of the response, we're very aware of the unexplained variation that exists across practices, and that's why tackling unwarranted variation is a priority for us and has been for the past 2 years. I will, though, just describe the process by which the data that was presented to us highlights this variation. So the question submitted presented data that is an expert from the CQC website. So the Care Quality Commission actually is the regulator for quality in primary care. On that website, you are able to find how your practice fares in terms of CQC rating. In Sussex, there are 10 practices out of 156 that require improvement, and we work with the CQC and those practices to make sure that they have action plans to respond to the CQC's findings in a timely way. The CQC take a risk-based approach to how they identify which practices that they review, and that risk-based approach takes into consideration both performance data that is nationally available and also feedback from the general public. And everyone is encouraged to give the CQC feedback in relation to the services that they experience. As I referenced right at the start, we are mindful of the variation that exists. And this year we launched a quality improvement scheme across the whole of Sussex that is supporting all practices to identify an area that requires improvement and work proactively on it. And we provide support also for practices who have got resilience issues. So we monitor a number of metrics on a monthly basis as an organisation, and that enables us to foresee where there might be issues and provide proactive support by way of either independent improvement support or indeed resilience funding from ourselves to make sure that we are able to sustain improvement within practices. So that hopefully gives a bit of an overview of both how quality in general practice is assessed, our response to it as an organisation, and what we're doing about the variation.
Well, thank you very much, Amy. Much appreciate that. So I see there's 1 or 2 questions starting to come into the chat, and I'll come to Natasha in a moment, but I think Martin was first. So Martin's asked in the chat, how big will the combined new ICB after merger be with Surrey Heartlands? And so maybe Mark Smith, you're our transition director as well as also the Deputy Chief Executive. Would you like to take that one, please? Mark, I don't think we can hear you.
Okay, apologies. Thank you, Stephen, and thank you, Martin, for the question. Are you all good now?
Yes, we can hear you. Thank you.
Fantastic. Thank you. Okay, cool. So I just, in terms of answering the question, Martin, there's a couple of ways in which we could do that. And I'll probably lead off from that Adam described earlier around the £19 per member of population and answer it from a financial perspective. But obviously, nothing happens here without our great colleagues and people working towards contributing to the Integrated Care Board. But in answer to your question, based on a population across Surrey and Sussex of just circa over 3 million residents, we will therefore be in an operating budget position of around £58 million. So I think it's important perhaps also just to give you some context in that space as to what the operating budgets for NHS Sussex and NHS Surrey Heartlands currently are, which is in a region circa of £129 million. So hopefully that just gives you the ballpark of where we are currently today, £129 million operating expenditure, and it will be £58 million in the new organisation. So I just thought that was probably the best way to answer it based on the £19 per member of population. Thank you, Stephen.
Okay, thank you, Mark. So that's, obviously this is still work in progress. I think we also need to accept that. And so no final decisions have been made on absolute structures because we haven't consulted with our staff yet. So, but that I think is why Mark has talked very much around the financial numbers that we're working towards. But we still need approval to proceed. So on that front, we're not able to go any further at the moment. Okay, but thank you for the question. Natasha, you've got your hand up, I can see online. Would you like to ask your question?
Oh, hi, can you hear me?
I can indeed.
Oh, hi, no, I just got an idea on how to save waiting times in the emergency department. Well, it is that I see a lot of people go in there and then they wait 4 hours after seeing the triage nurse, and then they eventually don't get. They go in to see the doctor eventually sees them, and then they get sent home with some pills. Now it's down to the triage nurse to sort of like put them in the right order, isn't it, to be seen? But what it is that wouldn't it be, they don't want to say go home, you're all right, you'll be okay, go home, because they're not a doctor. So I was thinking, wouldn't it be better to put a doctor as a triage? And then what happens is that he can give out the pill, send people home. He can give them, say, no, you've only got a sprained ankle, go home. Anyone that needs further testing goes actually into the hospital bit. That saves more nurses doing something that doesn't need to be there, and more doctors wavering around. Just one doctor, see people out the door, give a prescription for antibiotics or anything like that, and that would save all the people waiting around for 4 hours just for an antibiotic, or because they may not need further testing, and it would just take out a lot of them.
Okay, well, thank you for the question. I'll ask our Chief Medical Officer to come in a moment, but can I just ask, have you had personal experience of being in an A&E department, or are you a healthcare professional yourself?
No, I mean, after I've got four children, they're grown up now, but the times when they've smacked their head or done that, and I'm the doctor, and I don't know if they've got a concussion or something like that, and then you go down to A&E, and then you're stuck there for 4 hours because the triage nurse doesn't want you to go home, tell you to go home. She's worried because it'd be on her back be here, because she's not an actual doctor. So she's a bit wary about saying to you, no, it's all right, go home. So she'll make you sit there 4 hours. Then you see a doctor and you peel their head and you go, oh, no, you're fine, go home. But that's 4 hours in there with 4 kids or whatever to check one child out, and for anybody else that's in A&E.
Okay, excellent. Well, I'll tell you what, why don't I ask James Ramsey, our Chief Medical Officer, maybe just to talk about your idea around triage and what some of the opportunities or maybe the limitations are. James, would you be able to help us with this?
Yeah, thank you, Stephen, and thank you, Natasha, for that really helpful insight. I think what you're describing is the challenge that we face on a regular basis, and that is there is huge demand on our urgent and emergency care services, and there are multiple areas where people can access that care, but very often people don't know where they should be accessing the care based on the problem that they are presenting with, and therefore often default to urgent and emergency care like EDs. Now, we recognise that problem, and we recognise that it doesn't lead to a good patient experience. And so as a system, we are really trying to explore ways in which we can overcome that. And one of the areas that we have addressed within Sussex in our major service review is to actually review the urgent and emergency care pathway. And the suggestion that you are making, Natasha, about ensuring that we've got really effective triage is going to be incorporated in the new models of care that we are describing through the urgent and emergency care pathway. And we're hoping that we're going to get that endorsed by our public board so that we can then start to implement some of the new ways of working that our clinicians have been leading on. So thank you, Natasha, for your really helpful suggestion.
Okay. I hope that helps, Natasha. And just to sort of give you a heads up on the timescales, the new clinical pathway that James has just described is coming to our NHS Sussex board in public on the 24th of September. So just in about 3 weeks' time. So this is actually something that's actually very current. So a very topical question, and thank you for your interest. So just looking at the chat, I see that both Adam and Amy have been answering a question from Angela on the use of the NHS app. So hopefully I can see a thumbs up there. So hopefully that answers that one. I think Suresh, you've got your hand up on the camera as well. So would you like to ask your question, please? And if you want to come on camera, you're very welcome to.
Yeah, hi, Lightwood, Stephen. Regarding about these surgeries,
Yep.
if they see the patients properly, we don't need to end up in A&E at all. Because of the surgery neglection, they don't see the appointment, give the appointments to patients and see them properly. They're making people to use the other choice to get to A&E. Because of this, A&E is getting filled up. Most of them are silly, minor things where it can be sorted in the surgery, but surgeries are not giving the appointments to people. Are you able to sort these problems in the beginning? If they got for example, if they got liver infection or kidney infection, that can be done by surgery, by giving the treatments properly in the beginning, stop them going to A&E. If they don't do that, they are encouraging NHS, wasting the NHS money as well by sending them to A&E, and it's going to cost more money and all the rush in A&E.
So I think you ask a really important question here, and I'm just wondering whether again I could maybe bring Amy in just to maybe talk about not just so much about the GP access, but also about the role of integrated community teams potentially in helping to identify patients in advance. But Amy, I just wonder whether you'd be able to help provide some further context there.
Yeah. Absolutely. And I would be happy to link in separately to discuss your particular experience, because I think that might be helpful. Yeah. So please make sure you reach out to me, and I've put my email address in the chat if that's helpful.
Thank you.
No worries at all. It is really important that there is variation, and that variation partly also exists in the fact that GP practices operate to a national contract that has a requirement for appointments to happen within 2 weeks if clinically there is a need. Clearly, that judgment is often based on the judgment of that particular practice and the triage process that they have. But of course, that is something that we are trying to improve, because one of the points of feedback that we have heard loud and clearly from the survey that Stephen referenced earlier on today is the fact that members of the public in Sussex really want fast access to services. And that is still something that many people experience issues with. So I think it is an area where we need to make progress, but happy to pick up the specific case separately. In terms of the longer term and how this might link to improvements in the future, one of the things that we need to improve ahead of the winter in Sussex is for us to proactively manage people who might have what we call complex needs, so multiple long-term conditions, etc., in a different way and in a more proactive way, by actually making sure that we as a health service are contacting you as opposed to you presenting to us with an issue. And that's what we are working with primary care colleagues and community and the voluntary sector colleagues with ahead of this winter, to make sure that for those people who really need it, because of the complexity of their condition, we can contact them ahead of the winter months and try to preempt any exacerbation of illness before it actually happens. So that's just a practical way of how we are making integrated community care, or neighbourhood health, as you might have heard it described nationally, a reality locally.
Okay, hopefully that helps, Suresh.
Yeah, that's brilliant, Amy. But another thing is, when you certain surgeries, when you see on the telephone itself, they are saying, do not go to A&E or call 111. What's that mean? Because end of the day, if they don't give the appointment, people have to go to the A&E or 111, but they are blocking that channels on their phone calls. That is very bad, but I will speak to you. I will send you an email separately regarding that, Amy. Thank you. Thanks, Steve.
Thank you, Suresh.
Yeah, thank you very much. I think we've met before, haven't we, Suresh? So thank you for your engagement. Appreciate it.
Thank you.
So someone else that I've met before is Terry Steeples. So Terry, I think it's nice to see you back again. Would you like to ask your question?
It's not a question. It's a case of, in the presentation, they're talking about, I forget now whether it was yourself, Steve, but mentioned about the NHS app. I've been involved with that since the beginning, and I've been training people how to use it. The only problem is, out in the rural areas, people have had their phone lines disconnected. They haven't got a mobile phone, can't access the NHS app, and the other biggest problem is transport into such as hospitals who offer upper-state appointments, and there's no buses running. It's a big problem for some of our members. If they go to see their doctor, they have to see the doctor because they haven't got a pharmacy. They've only got dispensers to dispense the medicine that the doctor provides. So they're stuck in limbo, can't access the services that we gratefully provide for people in the towns.
Yeah. So I think obviously what's important here is that the NHS app is not going to be the only way to access the services, but for some people it is a valuable resource. Again, I'm just wondering, Amy, it's whether it might be useful to. I was wondering also about asking maybe Alison Cannon to just talk around what we're doing around some of our people engagement around this, because we have been listening very carefully to other members of the public. So Amy is responsible for the digital part of the portfolio, but it might be useful just first, Alison. I just wonder whether you could maybe say a little bit about what we've been doing about engaging people and particularly in the area of digital exclusion, because that's a very real issue for some people, isn't it?
Yes, thank you. And thank you, Terry, for the question. It's so important, isn't it, that people feel able to get the help, support, advice and access services appropriately. So in terms of the work that we've been doing here in NHS Sussex, we're working really hard to engage with our population, and we do that through a number of mechanisms. We do that through, as you know, asking people through surveys about some of their particular thoughts, comments, views, and where they find maybe challenges around answering and asking for services. Interestingly, through the most recent survey that we've had, we have had this raised with us in terms of the NHS app being a really important piece of digital technology that people actually welcome. But to your point, we have also heard that people feel that if they can't access it, they may be left behind or excluded from accessing services. So that's one way we are looking to gain feedback. The other way is around, as you know, working with some of our community champions and community connectors to really hear and empower local communities to tell us where they're really experiencing some challenging situations in relation to maybe digital exclusion, etc. We've also been having through our independent news panel, we've heard from younger people in terms of how we can use digital to help them access services. And through that also, we also heard about some of the challenges around some of the rural areas across Sussex. And probably the most important piece as well is we have a well-established digital and data panel that brings together local people who help us and support us on that journey in terms of how we may be able to solve some of the issues where there is some digital exclusion. And that digital and data panel has been running for quite some time and is quite vibrant in terms of really providing NHS Sussex with some really important feedback. So lots of things, Terry, going on, clearly much more to do, and we do hear this quite frequently around that digital exclusion piece, but hopefully I've been able to share with you some of the work that we've got in train, more to do, but we've got a good platform going forward.
Thank you, Alison. And I think Terry, the point is we want to provide choice, don't we? That's what we need to do, and I think we understand that.
What Amy's just said, it's the first I've heard, and we send out a newsletter. Rather Seniors Forum send out a newsletter quarterly. And on the back page, it's got a list of telephone numbers to get our members on the right pathway to get access, if they've got a telephone net these days. Unfortunately, one way that they could have accessed the computers was when the mobile libraries were coming round, but unfortunately, East Sussex County Council decided to stop the mobile libraries. But if something can be done with the village halls or the parish councils and get the information out to the people. Because we're only limited.
Okay, I think you've made a good point, Terry, and I think we do need to take away what we have to do in terms of maintaining other choices of access and communication. I think you make two really valid points there, as you often do. So thank you for your interest, Terry.
Just one more point, Steve. You said about coming back, see me again. I've been taken off the mailing list. I don't get the invitations to the board meetings for public.
Okay, I'll tell you what we'll do, Terry. We've got your email address, so I'm asking Laura Robertson, our Director of Communications, to take that as an action to get you back on the mailing list. Okay, thank you for that. Okay, why don't we come to Martin Emerson? So second question, Martin, is it related to the first one, or is it a second one?
No, it is a second one. Sorry to be rather greedy.
That's all right.
We heard earlier in the presentation from Adam that about half the current expenditure across Sussex is spent on acute, and the other half is spread across the rest of the services. I'm just wondering what plans are afoot to try and shift the emphasis from acute to more proactive services, perhaps to get us keeping healthier before we need the acute.
Well, I think that's a brilliant question, and actually, both Siobhan and Giles were at our commissioning intentions stakeholder event this morning on that very topic. And I'm just wondering whether I'll maybe bring Claudia Griffith in, who's our Chief Delivery and Strategy Officer, and is actually leading on some of the work because actually we do want to achieve that shift from hospital to community. So, do you want to maybe give Martin a flavour of some of the things we were talking about this morning, Claudia?
Yes, absolutely. Thank you very much for the question, Martin. I think really pertinent question at this point in time. So yes, we had a big stakeholder event today, which was talking about how through our commissioning intentions, we can really look at bringing to life and making very real that shift from acute to community and exactly some of the things that are required in order to underpin that. I think there was a huge buy-in from all stakeholders in the room about the need to enact that shift, and a real commitment to working together to look at how we do that in a very real way as we look forward into 26, 27. And I think starting to be really specific about what some of those proactive care models need to look like, as you say, in order to better support those who are at greatest risk of admission and, if not well supported, will be significant users of healthcare services. So how we really get on the front foot with that, how we start to really develop that neighbourhood health model, and bring together the different providers who can provide an effective wraparound type support for those patients with highest and ongoing needs. So lots of work going on in this space.
Great. And I'm sure next Council of Governors, Martin, you will be appropriately briefed, I would imagine, by your board.
I'm not a council governor anymore, but thank you very much, Stephen.
Okay, great. Oh, thank you, Martin. Natasha, is that an old hand or is that a new question?
Oh, hi there. Yeah, it's a new question. Hiya, can you hear me?
Hello again.
Yeah, hiya, can you hear me?
Yeah, I can indeed.
Oh, hiya. Well, what it is just one thing that's been worrying me. I've seen a bit of a trend of is that I've seen it go on and on. Is that I see a lot of private doctors, and my GPs have sort of like got price lists now, and for I expect private customers, private patients, should I say, or ones that are on insurance, or I don't know. But another thing is that there's another, like it's been before that I've had my daughter on a waiting list.
Okay.
And I've eventually got to see the man. No, what happened was I went to my GP and I said, can I see the a specialist privately to get her an echo test on her heart, which she was supposed to have because she's been on the waiting list for 2 years. She was only 5, and to see if her hole in her heart has closed. And so he booked me in for a private appointment. And then all this time that was understaffed and the doctor wasn't available, the specialist. Within a week, I got to go to the doctors, the specialist, and it was the same specialist that was too understaffed, wasn't available to see my daughter for 2 years. And then suddenly, because I was paying him, he was suddenly available. And also, there's more incidences where my uncle, he goes private, and he's going to a scan for whatever in NHS hospitals.
Mm-hmm.
And I'm thinking, are these private doctors paying to use our facilities, the NHS facilities? And if they are, isn't that backlogging the patients that should be having the x-rays and something like that? But these people that are going private are coming first, which is fine. I can understand that. Always thought, why don't we? Yeah.
So I think you raise a good point, actually. I think I'll maybe come back to Claudia again, if that's okay. Just in terms of actually where our responsibility starts and ends, because at the end of the day, we're responsible for commissioning NHS services, and obviously, patients' choice is really important, and patients do have the choice to do other things. But Claudia, I just wonder whether you maybe just talk about what our commissioning responsibilities are in this area.
Absolutely. Thank you very much, Stephen. So, yes, we have a responsibility to commission services and provide access to patients for the services that they need. We do use a mix of NHS provision and independent sector provision as part of that, and patients do have the right to choose services that they use and should be offered patient choice when going forward and discussing the treatment that they need. I think it is important to note that the independent sector provision does help us address some of the capacity challenges that we currently have within the NHS, and does form an important part of the provision that we use and that our patients have access to. But we do use that in quite a specific way to try and, in particular, support the areas where we have the longest waits. And one of the ways in which we've done that over the last 12 months is to really look at how we reduce waiting times for patients by accessing independent sector capacity for them. So it does make up an important part of the provision that we access. I just wonder whether I could hand over to Alison Cannon, our chief nurse, who was also keen, I think, to come in and provide some points.
Okay. Alison, would you like to just to add to this, and then we'll need to move on to the next question, if that's okay?
Thank you, Stephen. It was maybe going to be an offer to Natasha, because I'm very struck by the last couple of stories that Natasha has shared with us.
Yeah.
If I pop my email in the chat, I'm very happy to connect and maybe schedule in a specific call, and I could maybe get some further feedback, and that will help obviously feed into any sort of patient experience and improvement that we'll be doing across the commissioning of our services going forward, Stephen. Yeah. So I was just going to put my email and just offer that to Natasha as an option.
Okay, would that be helpful, Natasha?
Yeah, because there's a lot of things that I just always think the private ones are getting seen first, and then we're just backlogged, and that's why, because it's worth more to the GPs than to go for a private work and forget about us for a bit. So that's all I worry about. Well,
we don't want to forget about anybody, and it's really important that when we commission services that we do support our entire population. But what we'll do, Alison will leave her email in the chat function, Natasha, and if you want to follow that up, we'd be very welcome to carry on that conversation. Okay, thank you for your interest. Greg, I think you've been waiting patiently. Can I maybe come to you next?
Hi, Stephen. Yes, thank you.
Hello.
So I wanted to make a point that earlier on in the year, the NHS planning guidance, there was like a big decentralization of funding so that top performers could maybe have what they're doing and implementing copied and pasted to other groups and ICBs and trusts and stuff. Across Surrey and Sussex, as you're going to merge the ICBs, there's a really strong sort of AI research community, especially in Surrey. I wanted to see what your thoughts are on the clinical application of AI potentially for things like fracture detection that's got a nice early value assessment against it at the moment.
Okay, well, I think we've got a real research expert on our board, which is Monica Fletcher, and I'll bring Monica in a moment. But just in terms of, just give us some context, Greg, what's your background? Are you a healthcare professional, or have you got a specific interest in this area?
Yes, so I do research at King's, looking after some of the AI stuff. So just interested to see what you guys are thinking.
Yeah, no, it's great. Well, certainly we've created an Improving Lives Together through research strategy this year. It's one of our achievements that would have been on the film had we been able to fully play it. But Monica, you've got a strong interest in research. Would you like to maybe just explain how we're approaching this in terms of the applications of AI in particular? Something else
yes, absolutely
near to your heart?
Can you hear me all right?
We can indeed.
Yes, thank you. Absolutely. Obviously, thank you so much for the question, and it's very close to my heart because this is a world in which I operate both within the ICB but externally. And yes, we do have a research partnership across Sussex, and there is work across Surrey as well, to actually bring from particularly clinical leaders ideas on research. AI has so many applications, both in the front door, as you will know, of the NHS, and helping us to systemize things and to make things more pertinent for patients and easier to book. But as far as research is concerned, we have a wealth of data across Sussex and Surrey, but across the UK. So the work I'm involved in, and actually the ICB also, is one, how do we connect data sets, which we've done a lot of work across Sussex, but also how do we use that for research? Absolutely delighted to speak to you outside of here. I'm not sure if we've actually met. I've spoken to some of your colleagues around radiology and AI, and there is a lot of innovation. So yes, please don't think we're not thinking about this, and there's great opportunities for development across the piece in the future. So thank you for your question.
Yeah,
no problem. Thank you. That's really reassuring.
Yeah, I'd recommend you link up with Monica because actually she's a real expert in some of these areas, and so we're very, very lucky to have her on our board. So thank you for that, and thank you for your interest, Greg. And obviously we work really closely with the Health Innovation Network across Kent, Surrey, and Sussex, and I think that's actually a model that we'll continue to pursue as well. Sussex Partnership Trust also sponsors the Applied Research Collaboration here in Kent, Surrey, and Sussex as well. So we've got good partners. So great. Okay, thank you. Why don't we move on to the next question? That's from Helen Louise. Hello, Helen.
Hi. Well, I've got 3 questions, but I can just do one because there's not a lot of time left. How have ICBs improved patient safety in comparison to CCGs?
Okay, very, very important question. And I think I'm going to bring in our Chief Nursing Officer, Alison Cannon, again, if that's okay. So this is, Alison, patient safety has been a really important, journey for us. And you were involved in CCGs as well as the ICB. So you're very well placed to answer this.
Question, Helen. So it's a real focus, isn't it? Patient safety, both in terms of commissioning, but also in terms of providers as well. So there's a number of things, and you may well know that the patient safety landscape has changed over the last 12 to 18 months with the implementation of the Patient Safety Incident Response Framework. So as commissioners, we're really supportive of that framework for 2 reasons, mainly. One is it really encourages organisations to focus on the learning that happens through incidents and when things don't necessarily go right for patients. Our role then within NHS Sussex is to make sure that we're collecting and collaborating all that learning that happens across all the providers to set up what we call quality improvement networks and patient safety partner forums to really start that sharing and spreading of learning. So I think from my perspective as the Chief Nursing Officer for NHS Sussex, we've been on quite a journey in relation to patient safety. There's always more we can do, but we have really set up some really good infrastructures to really help support the patient safety agenda. And we've also supported the implementation of patient safety partners, both within providers, but also within NHS Sussex as well. And I know that isn't the case for all integrated care boards, and we're thinking about how we can utilise them to help support our decision making and through our committees as we move forward and we move into the work with Surrey as well. So I hope that's helpful. I could talk for quite a long time, Helen, around patient safety.
but it's a very clear focus. I think that's the point we would probably want to make, and we continue to work to new standards as they get published. So, but thank you for your interest, Helen, and good to remind us of the importance of quality. Richard, I think you were maybe next, and I think actually, if I'm correct, you're the chair of the High Weald Patient Participation Group, is that right?
Thank you, Stephen. Stephen, I have to confess, I asked the very first question that you read out about GP surgeries in East Sussex. I actually chair the Patient Participation Group network meeting for East Sussex.
Right.
And one of the things we find is with chairs and committee members of PPGs, that just the range of variation there is between the way different GP practices operate. And we were struck, we're very pleased for West Sussex, but we are a bit concerned about the 15.7% in East Sussex. I mean, that's 1 in 6. That's something like 85,000 people, residents in East Sussex, whose local GP surgery may be one that requires improvement. And Amy's answer was very helpful, very good, and it's good to know that there's a support program to try and help these GP surgeries improve. And she rightly pointed out that CQC take a risk-based evaluation approach. Absolutely. And I just wonder if that using the patient participation groups of those particular surgeries might be a way of getting feedback and monitoring through the patient experience as well as risk-based approach, if you see what I mean. It's a different perspective on the performance, and in some ways what patients judge is the responsiveness and their experience. And I just wonder that there's an enormous enthusiasm amongst patient participation groups to help their local surgery. And, I mean, as Terry Steele's pointed out, in rural areas, you haven't got a choice of GP surgery, you've probably only got the one. So I just wondered if there's any way in which patient participation groups, particularly in East Sussex, could help support the process that Amy was very helpfully describing to us.
Okay. Well, maybe I'll just bring Amy back in, if that's okay, just in terms of a perspective there, and then if we need to add further input from a communications point of view, we can maybe consider that too. But Amy, any particular reaction to Richard's suggestion?
Well, I think, Richard, you make a really important point. The whole purpose of patient participation groups being part of the GP contract requirement for them to have one is precisely to make sure that they are listening to the experience of people of their surgery and making improvements in relation to that feedback. It is an interesting point as to whether or not there could be a better link between PPGs and the CQC, and I'm sure that's something that we could discuss with the CQC as they themselves are going through changes in how they consider patient experience and feedback as part of their own changes. So yes, I think you make a really good point, and Richard, I'd be happy to talk to you further about it in due course. So my email address is in the chat, so please feel free to get in touch.
Okay.
Of course, if we can help the process, we'd all be keen to do that. Yeah.
Okay. Well, thank you for your interest, Richard. I really appreciate that. Very excellent. So thank you for your suggestion. Lillian, we've met before many times, haven't we, over at Horsham Hospital? So how are you today?
Fine, thank you, Stephen. My question is about cataract surgery.
Okay.
5 years ago, I think before COVID, we had a lot more local cataract surgery being done. And now I'm finding when I've gone to my opticians, I'm being sort of offered Brighton or Guildford. And I just wondered which opticians I need to go to get into, just going into somewhere in West Sussex for cataracts, or we used to have them at Crawley and other places, and I just wondered when it's coming back locally. It just feels that as an NHS service that we're fitting into a private business plan as opposed to the private business plan being fitted into the NHS.
Okay. Got it. So again, Amy, sorry to come back to you again, but actually just thinking about the commissioning of optometry services, will that be in your area, or would someone else be better placed to answer that?
It's not in my area, it's in Claudia's, but I think Lillian is quite a specific point, so it's probably one that both Claudia, we're just conversing because we're in the same room, you see. It's probably one that we'll need to take away and just look into further for you and to get you a specific response to the point of local versus otherwise, if that's okay. So we'll get in touch with you.
Yes, okay, thank you. It's just that my history, I think 30 years ago, I went out to Kenya and saw the Flying Doctor service out there where they did cataracts from the back of an aeroplane. And though I'm not saying that should be so here, it just means that 30 years ago, a developing country were doing more local services than we are here. Now, and it just
okay. I think let's follow up with you specifically on that particular case, because I think that deserves just further attention, if that's okay, Lillian. But lovely to see you again, and thank you for your continuing interest. Really appreciate it. Nita, I believe you're one of our staff members, so would you like to ask your question?
Hello, lovely to meet you, Stephen. Can you hear me?
Hello. I can indeed. Thank you.
Oh, great. I've just got a question about nursing homes. So the CHC have patients who are in the nursing home, which is funded by us. And so some patients range from, let's say, 30 to in their some of them 100. So some of those patients have had cancer or whatever, and they've got mental health problems, and they can't go out to provider land to be seen by a consultant, doctor, or whatever. And sometimes you get health public health sending them letters to have scans and all that, and they can't get a mammogram done or anything like that. But I've just thought going forward in the future, there are some devices which can be brought into nursing homes, like ultrasound scans. I mean, they usually do a regular checkup, but sometimes some of these patients don't have a voice, and they're run by people in the nursing home who may think you might not be the correct voice for them. That makes sense.
I know, I hear exactly what you're suggesting.
And
there.
and they miss out, and they're meant to have every 5-year scan because of their disability or ADH, you name it, or they're too terrified to go into the hospital, sit with people. You get that kind of group. So I feel like those kind of group are left out because they are, what's the word? They are governed by the nursing home staff.
Yeah. So I think you
and they don't have a voice. And they don't have a voice.
Yeah. I think you raise an important question here, actually, and unfortunately, the ideal person to answer this would have been Mark Stainton, who's our adult social care, partner member. But Alison, obviously, as Chief Nursing Officer, you're also responsible for our, continuing healthcare responsibilities. And I just wondered if there's any sort of assurance you could give to Nita on this issue.
Thank you, Stephen, and thank you, Nita, for raising the question. It's a really important and valid question. I think there's just a couple of things I would just say in response briefly. I think in terms of if a person is funded through all age continuing care or CHC, so continuing healthcare, we make sure that there's an assessment done, so we understand what the needs of that individual are, and we would help and support from a commissioning perspective to ensure that the right in-reach into nursing homes was happening. So we do know that we have GPs that go into nursing homes to see patients, and we do know that we have community services that also go in to see patients, both who are in receipt of continuing healthcare funding, but also who are may just be having funded nursing care or are self-funders. I think in terms of, as Nita has described, that there will be, and of course technology is always improving, isn't it, to enable if you like, treatment or scannings, etc., to be brought into not just nursing homes, but people's homes. And I think as we move through the next few years, we'll see that becoming more and more available to people. So I think in short order, Stephen, they would be the two things that I would sort of just say back to Nita, but I know it can be a particular concern. But I think the other thing that is really important to say is if a person doesn't have if you like, the ability or the capacity to make decisions, because I think that's what I heard a little bit from Nita. It's important that the nursing homes and people around them have independent advocates that can help and support those people with decision making as we move forward. So they would be the three things that I would say.
Okay, well, thank you for that, and thank you for your question.
Can I just add, from my experience, you've had advocates and you're relying on the nursing home, and yet they didn't speak up for the patient, so they were just forgotten.
Okay.
You know, it's just like, do you remember when COVID came along?
Yeah.
Those people in the nursing home were forgotten.
Yeah.
Of course. And we learned a lot through COVID, Nita. We did learn a lot through COVID in terms of, you know, the experiences of people who were in nursing homes. So I completely, you know, hear and understand that. And, you know, we have to continually keep tending to these things. And when we hear these sorts of feedback, we just need to go back and retest ourselves to make sure that we're doing everything we can to support the care and residential and nursing homes to be aware of what is available in terms of independent advocacy for patients.
Yeah.
Right. Thank you very much, Stephen and Alison.
Thank you, Nita. Yeah, cheers. Thank you very much. Helen, I saw you nodding vigorously at that particular on that particular question. Is this a related question, or is it a different point?
I mean, it's a nice little final one if you want it.
Go for it.
Okay. You're going to need to make 3% savings on your, not on your operational costs, on your service costs next year.
Yes.
That's what, yes, I've had a discussion with Steve Phoenix at East Sussex Healthcare Trust. That's 183 million. How are you going to do it? Where are they going to come from? And how are you going to measure that the consequences aren't patient safety or very negative?
Yeah. Okay, well, I think you raise a very simple question at the end here. No, so it's a really significant point, actually. But and I think the best person to take this on is probably Carla Moody, who's our interim chief finance officer. And Carla, this is something that we have been thinking about extensively in recent months. So, yeah, do you want to just provide some assurance that this is not going to be just one sort of a simple decision? This is going to be a longer term process of how we get to there, part of our medium term financial planning, perhaps?
Yes, thank you, Stephen, and thank you, Helen, for the question. So, I think when you're talking about the 3% savings that we need to make, are you talking about specifically creating an investment fund to enable the?
No, I think we're talking about the fair shares allocation, Carla.
Oh, the fair shares allocation. Oh, yes. So yes, sorry. Yes. So that's correct. So from an NHS England perspective, Sussex is overfunded in terms of the fair shares allocation methodology. And they've been applying a kind of convergence factor. So over a number of years now, the last couple of years, the funding is being sort of slowly withdrawn from Sussex, and we have taken account of that as part of our planning process, and that has then informed our distribution of the allocations to our system partners, and has been part of the sort of efficiency that we've built into our plans over the last couple of years. I think we are anticipating that there may be an acceleration around the recovery of that overfunding, but the pace of change has yet to be determined by NHS England. So I think we're anticipating that will be the case. We're waiting for our allocations for the next 3 to 5 years, and that will be part of our medium-term planning process. And we will obviously look at it in the round as and when we get those allocations and the guidance that is associated with that. I suppose in terms of the specific impact and the risk. So as things currently stand in 25-26, as I sort of indicated at a fairly high level, it's a really challenging financial year, and actually as a system we have an efficiency of around 6% built into our NHS ICB and provider organisations' efficiency plans, and what we do in working up those plans is make sure that there are really robust processes that look at the quality impact assessment and the EHIA associated with any changes that we make around the way that we commission services, or where we are looking to make efficiencies. So that is definitely something that is embedded in our day-to-day existing process, and something that we will obviously look to build on and continue to take forward as we look ahead to medium-term financial planning, and we're notified of the allocations that we will have to support that. So yeah, okay. I suppose just some assurance that's it's already part of our existing processes. And
thank you, Carla. Thank you. Thank you. It's one of those questions that we all know it's happening. I come to these meetings and I know you are very confident in communicating your positives. You're all very confident in that. I know there are negatives, and Carla, accounts always come through with the negatives because you can't make up the facts and figures. So thank you for that. Thank you.
Yeah, that's great. Okay, well, thank you for your interest. I think it's unlikely there's going to be all taken out in one go. It'll be phased and it'll be planned appropriately, and then we'll do any inequality impact assessments on any changes in services, which is our normal process. So thank you for that. I'm just conscious we're running out of time, but I know, Sunita, you've been very patient, and I just want to maybe give you the opportunity to ask the last question before we maybe have to close the session. But Sunita, would you like to ask a question?
Yes, I appreciate that. Yes, my name's Sunita. I'm a parent, a carer of a daughter with mental health issues, and I really appreciate the presentations you gave at the beginning. Okay. And I was interested to know that, what a huge amount of money is spent on mental health services. Sort of the question and the feedback I wanted to give really is that my daughter's neurodiverse and she started having mental health problems 5 years ago. So she was on the older end of children's services at the time and then tried to move to adult services. So I guess my main point on this is that the assessment process, which she's probably had hundreds of assessments now,
right,
was overwhelming and very, very detrimental to her mental health. And the amount of professionals that she saw through that process was a huge waste of money. It should have been done once or twice, and the same questions being asked. And if you imagine someone who's very, very vulnerable being asked constantly, maybe on a monthly basis, things like really detailed questions about what abuse have you suffered when she hasn't suffered any. Right. Why do they have to keep asking the same questions, all these different services? So it's not only the mental health services, it is obviously the NHS services, but also the council she's got in the HCP. They have to ask the same questions. She's got PIP, so the benefit services asks that. They're all incredibly lengthy. They're all incredibly detrimental to her mental health, personally, and also to my relationship with her, where I'm trying to encourage her to engage with this, and I can see the fallout from it. And then any services she does get access to, because I know they're really hard pressed. Every professional's been brilliant as an individual. Obviously, if she doesn't make an appointment, if she doesn't keep an appointment, she's discharged straight away. But that's part of her condition, that she's not always well enough. So there's lots of things around it. And I'm not talking only about my personal experience. I'm part of the PPG. I have a health policy background. I'm an analyst. I'm part of Carers Network. I'm linked in now with Possibility People, who are telling me about how the future might look. I have got a lot of feedback to give and have given it to other people. And the GP who supported my daughter through all of this was saying that the system's broken. She's a mental health specialist. I have very good ideas on how you could reduce the cost of these services and provide a better service.
Well, I think we need a longer conversation with you, but maybe I could just bring in Jane Padmore, who's not only our mental health partner member on our board, but is also the Chief Executive of Sussex Partnership Trust. And Jane, I'm just wondering whether you could just provide a quick response in terms of how we could maybe get to know the situation that Sunita's been talking about and what we could maybe do about it.
Thank you. Can you hear me?
I can indeed.
Lovely. Thank you very much. Hello, Sunita. Thank you for sharing your experience. A couple of things, really. One is I completely agree with you. It is very frustrating telling your story over and over again. We are introducing a new electronic patient record that speaks to the GP system, so that we hope to minimise that more. But I wonder whether if I put my email address in the chat function, we could talk to you about your experience, so that as we're transforming CAMHS and transforming our adult services, you can feed into that process so we can hear your story.
Yeah, I'd certainly be happy to, because it's a very essential service, and you're obviously hard pressed in terms of finances. So yes, certainly happy to do that.
Okay, well, thank you for that, Sunita. Really valid point, and thank you for your contribution there, Jane. Natasha, I'm sorry we're out of time now, actually, really, to ask any more questions. So I'm just wondering whether if you take the opportunity to speak to Alison Cannon, maybe you could pick up that question there. And similarly, Mel, I think we are unfortunately out of time now. But what I'm going to suggest in a moment, I'm going to play the video that we weren't able to show earlier. But if you maybe want to put your question in the chat, we can then maybe get an answer to you that way. But I'm just conscious it's 4 minutes over.
The chat thing.
So,
I didn't know how. I didn't know how to, because it says it's turned off on this meeting.
Yeah, if you go into Q&A, if you go into Q&A rather than chat, that's where you'll find it. and you'll be able to just post your question there.
Because I couldn't find it. All right then. Yeah, it's just a quick technical one.
Natasha, I don't think it hasn't been enabled for some of us, so don't worry.
Yeah, no,
okay.
It's on Q&A, not on chat.
We don't have Q&A enabled, Stephen. Sorry.
Okay.
Okay. So I don't know how to get the bit that you were going to send through.
Okay. What we'll do is, Natasha and Mel, what we'll do is we've got your email addresses through this. I'll ask our communications team to contact you directly so that we can then actually get your questions that way. But I think we are going to have to bring the meeting to a close now, I'm afraid.
Yeah, sorry, Stephen. I can't see then also Jane's email address because I can't see the chat either. It's Sunita Shear. So it'd be great if she could email me. That would be great. Thank you.
So, okay, what I'll do is Laura, our communications director, is just taking a note. So Natasha, Mel, and also Sunita will contact you and make contact with you by email that way. Okay.
Yeah.
So I think, look, we could go on for hours, but I want to be respectful of everyone's time, I think, and it's probably all we've got time to do today. But I think what we've heard today is about the immense amount of work that has taken place over the last year. And, we do, as Adam was talking about, have a clear ambition for providing high quality and accessible health and care services for the whole population of Sussex. We don't get it right all the time, but we absolutely want to try, and that's absolutely our ambition. I am really proud of what we've achieved, and what I'm going to do for those that are interested, we've got the video that we couldn't play earlier. I think we've hopefully solved the gremlins. We're going to play that in a moment. It's just over 4.5 minutes long, so anyone who wants to stay on can do that. Just before I ask Harriet to play the video, just also want to just say a couple of words about myself. This will be my last annual general meeting as the chair of NHS Sussex, because I'm actually going to be retiring at the end of this particular month as my 3-year term comes to an end. So I would just like to take this formal opportunity to record my sincere thanks to Adam Doyle, our Chief Executive, all of our board members, our system partners, and everyone on the call for your consistent support, your constructive criticism, and your active involvement. I do honestly believe the NHS is the most incredible and unique health service in the world. And that's exactly why we need to nurture it, we need to support it, we need to develop it, and we need to appreciate it. And I think that's certainly something that I will do when I become and I'm a resident of Sussex, and hopefully will continue to use the services personally as well. So thank you for joining our AGM today, and just really to play us out, I think we'd like to try and show the video which really gives a summary in one simple video of all the things we've been doing over the last year. So thanks for your interest, and play the video, please, Harriet.
Hello, my name's Stephen Lightfoot, and I'm the chair of the NHS Sussex Integrated Care Board. And this short film provides a summary of the many achievements of the NHS in Sussex over the last year, from April 2024 through to March 2025. And it's a story about people. Firstly, the 1.7 million people who live in Sussex, and then of course the NHS staff, our partners and our volunteers who provide the vital health and care services for our population when they need us most. And it's about how we're working together to achieve our shared ambition of improving lives together. Now, when we ask the public about what they want from the NHS in Sussex, people tell us they want high quality healthcare. They want to be seen quickly, they want to book appointments online, and they want to be seen in a location that is convenient or accessible for them. Now, in general practice, we've recruited more GPs and other healthcare professionals. We're linking our GP practices to the NHS app, and we've introduced better telephone systems. So our 156 GP practices have been able to deliver almost 1 million GP appointments per month in Sussex. Our 300 community pharmacies across Sussex have also delivered an additional 190,000 consultations through our Pharmacy First scheme. And our 300 dental practices provided more NHS dental appointments so that 35% of adults in Sussex have been able to access an NHS dentist in the last 2 years, as well as our new urgent dental care service. In urgent and emergency care, our ambulance service provided some of the best response times in England, and our hospitals worked hard to give Sussex the 10th best performance in the country on waiting less than 4 hours in A&E. We also introduced care navigation hubs and increased capacity in our urgent community response teams, so people don't need to go to hospital if they don't need to. In community health services, we've been able to increase our virtual ward admissions by 39%, so we can treat more people at home. And we've been able to provide more mental health contacts to meet the growing demand for our mental health services across every age range in the population. In planned care, we've expanded our network of community diagnostic centres, and we're delivering more diagnostic scans and tests than ever before. And our hospitals reduced our total patient waiting list, with a real focus on reducing the number of people waiting more than 65 weeks for treatment. We also have a responsibility to improve the long-term health of our population, to help more people live healthier lives for longer, regardless of where or how people live. So we ran a programme of targeted lung health checks that have diagnosed early-stage cancer in over 100 patients who didn't have any previous symptoms. And we ensured that more than 3/4 of people with learning disabilities in Sussex received their annual health check. We're also investing in the future and building new state-of-the-art healthcare facilities, such as the new Coombe Valley Mental Health Hospital in Bexhill, the new Sussex Surgical Centre in Eastbourne, a new emergency department and new Sussex Cancer Centre in Brighton, a new integrated care centre in Worthing, a new acute stroke centre in Chichester, and new community diagnostic centres in Bognor Regis, Crawley and East Grinstead. And we're continuing to innovate, with strong public and partner involvement in the development of our new Improving Lives Together through research strategy, and also the development of our new Sussex data strategy, as well as the development of new care models for our 13 integrated community teams and other major services, so we can build a sustainable NHS in Sussex that is fit for the future and aligned with the government's 10-year health plan. And of course, none of this would have been possible without our brilliant staff, both in NHS Sussex and of course in the wider health and care system across Sussex. And with all the uncertainty that is on the horizon, the professionalism and resilience of our staff is really outstanding, and it really makes the achievements of the last year even more remarkable. And finally, thank you to all our partners in the NHS, our local authorities, our voluntary sector colleagues, our universities, our colleges, our Health Watch colleagues, and of course everyone else who's contributed in some way to help us deliver another year of growth and improvement for the population of 1.7 million people on our journey to improving lives together. Thank you.
And I think that is probably an appropriate way to finish our annual general meeting for 24-25. Really apologies about the gremlins earlier, but I think we got there in the end. So thank you very much for your interest. We'll continue to do the very best that we can for the population that we serve, and we'll see you all next time. Thank you very much. Bye-bye for now.
Bye, Steve.